So I might introduce the next speaker, Dr. Brian Feeley, Professor in Residence, Chief of Sports and Shoulder Services at UCSF, trained in Stanford as a physician, orthopedics in UCLA, sports medicine in New York. He's a softball coach, he's a team physician, or was, I don't know, for San Francisco Giants, and he's a surfer. And he's the person who I sent shoulder pain patients to who want alternative medicine with me, and they want a no bullshit examination by him. Brian, you're on.
All right, can you see my screen?
Yes. Yes.
Okay. I'm going to just make sure that this works. All right. Sure. All right, so I'm going to talk about the regenerative capabilities of paraspinal muscles. So I really appreciate the time to talk to everybody. What I'd like to cover in this talk is a little bit about stem cells muscles, or stem cells within the muscle, and particularly these fibroadipose progenitor cells, or FAPs, how they relate to muscle injury and regeneration, and talk about how this relates to muscle degeneration in the spine. Now, for the most part, I'm going to talk about shoulders today, but for those of you, and probably most of you who are into spines, you're going to see this as a pathway to discovery, since honestly, shoulder is probably about 10 to 12 years ahead of spine in terms of understanding the influence of muscle quality on both surgical and non-surgical outcomes. Now, this paper presented by Dr. Gladstone in 2006 wasn't the first paper that looked at muscle quality and rotator cuff outcomes, but it was the one when I was a resident that I read and realized, gosh, we really don't understand much about muscle in comparison to the other aspects of orthopedic surgery. We tend in orthopedics to understand how bone injuries happen, how cartilage injuries happen, how we can affect these changes. But in muscle, it really wasn't found to be that prognostic until this study. Now, at this time in 2006, the thought was that if there was a rotator cuff tear, the angle of the muscle fibers changed. So there'd be a change in this pennation angle, and that would allow the fat to creep in or infiltrate. And Christian Gerber's work was why they started calling this fatty infiltration. And what they felt was that fatty infiltration was not necessarily a degenerative process, but a necessary rearrangement of tissue after changes in the muscle caused by the musculotendinous retraction. Now, if you think about that for a minute, if it were true, it could only happen in situations where there was tendon detachment or other changes in angles. So for instance, you wouldn't see fatty infiltration in paraspinal muscles, and you wouldn't see it in the infraspinatus if that was attached and you only had a supraspinatus tear. And seriously, from a biologic standpoint, this actually makes not that much sense. So over the last 6 years in our lab, we've focused on the identification of the cellular source for fatty infiltration and whether or not this is preventable or even modifiable. When we think about stem cells within muscle, satellite cells are the most common, especially in kind of a neutral resting state, but they do not typically have the ability to differentiate into adipocytes, even in vitro conditions. So pretty much no matter what we do to satellite cells, they are kind of on the differentiation pathway to become just muscle. There are a variety of other stem cells within muscle. Vascular parasites have been shown to be pluripotent and have been studied by others and have some promising ability to help in time of muscle regeneration, but that's probably through increasing vascularity. But we focused on the fibroadipocyte precursor cells, or FAPs. And it turns out that not only are they pretty well named, but they appear to be a pretty good potential source for fatty infiltration. Now, FAPs were first described in an elegant series of experiments in the early between 2009 and 2011. This study by Dr. Ozimi found that these FAP cells are developmentally distinct from other muscle stem cells. And in vitro, they were able to be shown to be able to be stimulated into either fat or fibrotic tissue. So we felt like this is probably a good candidate cell population for fatty infiltration. And we wondered what other phenotypes these would be able to be differentiated into. Now, over the last 5 years, there's been an explosion of studies looking at FAPs in a variety of different disease processes. And this figure is from Tom Rando's recent study in Cell Reports. But in a nutshell, there is a standard pathway that occurs. FAPs assist in muscle regeneration in normal injury states, but in chronic disease processes, these are shunted towards different pathologies, including fibrotic and fat pathways. And what we've seen is that in acute injury states, such as a direct muscle injury or ischemia reperfusion injury, you'll get FAPs that essentially do exactly what we want them to do. They get injured, they proliferate, and they assist in muscle regeneration. But in chronic states, like most orthopedic conditions, including low back pain and rotator cuff injuries, they seem to promote this injury and degenerative condition. Now, we've done several experiments focusing on the rotator cuff, and we find that these are primarily the cells that are of most interest in terms of both degeneration and regeneration. Now, in these series of experiments, and just to summarize in the interest of time, we found that FAPs are present in the rotator cuff and they're preferentially expressed compared to other muscle subtypes. We found that FAPs expand after rotator cuff injury, especially in the first few weeks after rotator cuff injury. A subpopulation, but not all FAPs, become adipocytes after rotator cuff injury. But interestingly, there's also a group that do not become adipocytes. And treatments that block FAP differentiation are able to decrease fatty infiltration, and that includes at a pathway type level and as well as with FAP depletion studies with mouse models. So now, why is this important? Well, in 2017, or not too many years ago, the general consensus was bad FAPs will turn into FAPs. So the paradigm is you get a rotator cuff injury, and then these FAPs go down a degenerative processes, whether that's primarily fat or some fibrosis, which we don't talk about mainly because we don't have the ability to image this in clinical studies. But what if there's a reason that we have this highly specialized type of cells that are able to differentiate in between different subtypes? And what if this fatty infiltration is primarily more of a regenerative process? So if we go back to med school or grad school, depending on where you last trained, we remember that fat has been derived from a common source, but it's actually broken down into 3 subtypes. What most of us have is a white fat cell, and that's the predominant type of fat that we see. There's brown fat, which we have is essentially, especially in small mammals, as a shivering or highly thermogenic type of fat. And then there's the beige fat cell, which we'll focus on for the rest, which seems to be kind of an intermediate between brown and white fat. And this is marked primarily by the expression of UCP1, which allows these adipocytes to generate heat. So when we looked at our rotator cuff injury animals, we found that about 50% of the FAPs actually are able to express UCP1 without any special induction. And we found that, so therefore, that about half of the FAPs that are present after a rotator cuff injury in a mouse model are potentially in this regenerative state. And these are the cells that are stained pink in this, which are co-expressing next to the green cells, which are our FAP. So about half of the cells, both in males and females, seem to be able to express this pro-regenerative or pro-thermogenic signal. In vitro, we took FAPs from both mice and human muscle, which we took as surgical waste from ACL grafts. And we found that when we stimulated these cells with a particular drug, in this case, rosiglitazone, we could take FAPs that were already differentiated into white fat and turn them back into beige fat. So that's what you see both in the top column, which is 2 separate time points. The red globules are essentially adipocytes, and they decrease after rosiglitazone expression, and this is a single cell time course. And so this is a fat cell on the bottom left at 0 hours. There's no UCP1 expression, and after 24 hours, you see all these fat cells are expressing UCP1. So it suggests that even though we think of white fat as a terminally differentiated type of cell, at least within muscle, if it's derived from this stem cell type, it may be able to differentiate into beige fats. We then did a variety of relatively simple co-culture experiments and showed that FAPs are able to, FAPs that have a beige phenotype are able to stimulate satellite cells to become myotubes. And that's what you see in both mouse and human tissue. If we use normal FAPs compared to beige FAPs, we see, especially in the human tissue, that a majority of the satellite cells over 2 weeks are able to differentiate into primary myotubes. This is interesting because other studies in our lab have shown that satellite cells also increase in proliferation after rotator cuff injury, suggesting that in this model that they may be primed and waiting for some sort of differentiation source, such as whatever the FAPs that have this beige phenotype are able to express. So what about in vivo? We wanted to create a clinically relevant model that would recapitulate what we see in the human condition. And that's essentially, this busy slide shows what we did over the course of a series of experiments. We took a mouse injury where we do a tendon transection and the denervation of the rotator cuff, and that's kind of our classic injury model at this point in time. Let this develop for 6 weeks. And then did a repair, and then 6 weeks later, we looked at gait and histologic outcomes. When we look at this screenshot, I think the important column is this tendon transection group. So you see oil red in the supraspinatus and in G, and then in Q in the infraspinatus. Just with the injury, we see a fair amount of fatty infiltration. 6 weeks, if we do a 6 weeks delayed repair, we see an improvement in the amount of fatty infiltration, but it doesn't disappear. And the same thing is seen with our gait analysis. We see as that the amount of recovery is pretty good and not perfect. Now, this is actually a really good model because that's exactly what we get with rotator cuff patients, even with successful repairs. We essentially see that the muscle recovers, but not completely, and your function recovers, but not completely. So this, we felt, was a good model to test sort of therapeutic treatment strategies for mice with rotator cuff injuries. So now that we had this repair model, we wanted to see if we could stimulate the endogenous muscle stem cells, or the FAPs, to become beige fats and improve muscle quality. In order to do so, we looked at 2 clinically relevant treatment models. The first was, we said, okay, well, you have this rotator cuff injury or tendon injury. And what if before surgery, we treated you with a therapeutic, in this case, amibegron, which is a beta-3 adrenergic agonist, which we know from other studies turns on beige fats in a specific muscle-dependent way. Or the second scenario, you come in for surgery, you have your rotator cuff repair, and then you have a treatment as you're on your way to recovery. Now, unlike in humans, where we can't just go and harvest the muscle 6 weeks later, we had a 6-week time point so we could compare to previous studies and did a variety of analyses. Now, what we found was that I'm going to focus on the delayed treatment just in the interest of time, but the delayed amibegron treatment was able to decrease but not reverse atrophy. And again, this is only 6 weeks of treatment, but the control shows relatively little or negligible weight loss compared to a pretty considerable weight loss after just injury, which we were able to decrease by about 50%. So probably about a 50% improvement with overall atrophy measurements. When we looked at our immunohistochemistry, when we compare our injury model to after repair, or repair model to repair plus treatment with amibegron, we see in the bottom column a considerable increase in UCP1 expression. So there's more beige fat being expressed with the amibegron treatment, and we see a concomitant decrease in the amount of fatty infiltration. We aren't able to completely reverse it, but we see a pretty good decrease compared to what we see with just repair alone. When you look at gene expression from these cells, it's pretty interesting. When we look at the treatment with amibegron, either immediately or with delayed treatment, we see in the right column of each of these genes, or gene selections, we see a decrease in expression of pro-atrophy related genes, a marked increase in brown fat related gene expression, a decrease in white fat expression. But interestingly, we also see increases in IGF and follistatin isoforms, which we know are factors that are important in myogenic regeneration. So it seems that this is expressed out of these FAPs, or the expression in the whole muscle afterwards is markedly increased when you have FAPs that are expressing these beige fat phenotypes. Now, importantly, when we did these studies in UCP1 knockout mice, we don't see these effects. So even treatment with amibegaron was not able to decrease the amount of fatty infiltration. So this seemed to be specific to these cells. So at this point, we felt like the FAPs are an endogenous inducible source of beige fats. Pharmacologic treatments can increase FAPs into this beige fat phenotype, and this may allow us to improve muscle quality. However, I know most of you are thinking, especially Dr. Lotz, that this was a spine conference. So what does any of this have to do with spine? As you've heard earlier today, and we're starting to understand, that low back pain is related to atrophy and fatty infiltration. And this has been shown in multiple studies, I think really nicely highlighted by Dr. DeVere and Roland's presentation earlier today. We wanted to ask the question of, well, if fatty infiltration is important, and we see it in rotator cuff injuries, and we see it in paraspinal muscles, is there something similar about these muscles that's different compared to the other muscles? So using a mouse model, we hypothesized that FAPs would be at a higher concentration in the axial skeleton compared to the appendicular skeleton, with an overall phenotype that was similar to rotator cuff tears in the paraspinal muscles. So we did a relatively straightforward study. We essentially took muscle samples from multiple muscles from a mouse, and then isolated them for FAP overall numbers. So this is without an injury, but we looked at a variety of different cell types. So masseter from essentially around the jaw, supra and infraspinatus and paraspinal muscles, so rotator cuff and paraspinal muscles from the spine. And then we looked at more extremity muscles, including the triceps, gastroc, and tibant. And that's important because when we see extremity injuries, the predominant injury phenotype is fibrosis rather than fatty infiltration. And when we look at the percentage of total nuclei, what we find is that, not surprisingly, in the supraspinatus, infraspinatus, and paraspinal muscles, as well as in the masseter, there's a higher percentage of the total nuclei that are FAPs compared to the more extremity muscles. So these FAPs tend to be more centrally located within these muscles. We then wanted to see whether or not they had more adipogenic or fibrogenic differentiation potential. So we then treated these cells in vitro with either pro-adipogenic or pro-myogenic media. And in pro-adipogenic media, we find that the supraspinatus and the paraspinal muscles were much more likely to be able to turn into fats, with the rotator cuff about twice as having twice the ability compared to the paraspinal muscles, but much more than these more extremity injuries. We also found that there was considerably more regenerative potential, and with markers of stemness, which we used with a BRDU stain and a Ki67, there's considerably more kind of stemness markers and the ability to regenerate or differentiate into multiple phenotypes in these centrally derived FAPs compared to the more peripheral derived FAPs. So from this, we concluded that FAPs are present in higher proportions in rotator cuff and paraspinal muscle, and that these muscles these FAPs from these muscles had higher adipogenic and proliferative potential compared to the hind limb muscles. And this may be why the axial muscle tends to be more likely to develop fatty infiltration. Okay, so what about in human studies? And like Roland just presented, this study was done in part with Jeannie Bailey, where we looked at a relatively small sample size. We took 10 patients who were having decompressive spine surgery for a lumbar disc herniation, and compared to hamstring muscles for healthy controls. And this is a representative histologic slides from this study. On the left is oil red O for fat, and on the right is trichrome for fibrosis. On the top column is a sample of multifidus muscle, and on the bottom is hamstring. Hamstring should be essentially normal muscle. And we see a considerable increase in the amount of fat and fibrotic tissue in this paraspinal muscle sample, which was pretty consistent through all 10 patients. We then wanted to look for overall cell numbers. So we took a separate sample from each group and subjected it to a cell sorting, and then did a rigorous cell sort for both FAPs and satellite cells in the multifidus and hamstring. And we found that in comparison, the overall number of FAPs is much higher in the multifidus, around 11.5%, compared to the hamstring, which is at 1.5%. There was also a significant increase in satellite cells compared to hamstring as well. And the normal muscle tends to have 0.1 to 1% of your nucleated cells as satellite cells. So we see again that these injured muscles have this regenerative milieu of cells with a higher number of FAPs and a higher number of satellite cells. We then looked at gene expression within these samples, and for better or for worse, we only looked at one fibrogenic gene. We looked at alpha SMA, and for reasons I'm not entirely clear, we then did a whole panel of pro-adipogenic genes. Sorry, I'm supposed to start clinic soon too. But what we found was that there is a considerable increase in pro-adipogenic genes, which is not surprising. We see an increase in adiponectin, CBP, FABP4, which are all pro-adipogenic. But interestingly, we also see an increase in UCP1 expression, suggesting that these FAPs will also have a beige fat phenotype. So finally, thanks to some recent funding from Jeff Loetz and the REACH group, we're able to start looking at a mouse model of back pain. And for those of you that haven't figured it out, I do love building mouse models that mimic rotator cuff disease or human disease processes. And I also like making PowerPoints that include really fancy lightning strikes. And I think I did a pretty good job of looking up back pain on the internet and seeing this is what back pain looks like. And it looks almost exactly the same on this proximal junctional kyphosis. But with this, we're looking to see if degenerative disc disease can cause muscle degeneration in paraspinal muscles. So we hypothesized that degenerative disc disease can cause alterations within the local niche, which will result in genotypic and phenotypic changes in the muscle stem cells, particularly these FAPs and satellite cells. These alterations will subsequently govern the degenerative muscle changes, which result in worse function through a differentiation into fats and secretion of pro-inflammatory and pro-atrophy related factors. So our design is to build this mouse model of disc injury and degeneration to study how this affects all parameters, including their gaits. So the mice essentially get injured on day 0, and they get sensory and motor testing on a weekly basis. We have essentially gotten through 6 weeks of testing and found that the sensory injury recovers at about 4 weeks, and the motor injury recovers at around 3 to 5 weeks, depending on how many disc levels we injure. We're currently at the point where we're going to start looking at the alterations in FAPs and satellite cells within this muscle. And then we'll be able to look more particularly at these cell types by looking at how these FAPs interact with their surrounding tissue and regulate muscle degeneration. So in conclusion, from these relatively newly done studies, we conclude that the multifidus in patients with disc herniation contains a pretty large percentage of FAPs and satellite cells. So it seems to be a muscle that with the right treatment will be able to have some sort of regenerative capability. We found that the multifidus in patients with disc herniation also has different gene expression profiles compared to a normal muscle. So again, the stem cells seem to be turned on compared to a resting quiescent muscle. And we hope that these animal models that we've just started will help back up this research. So in summary for this talk, we've found that FAPs are an endogenous stem cell source that are responsible for muscle degeneration in a variety of disease states. And I think one of the nice things about working at UCSF is the collaborative ability has allowed us to expand into muscle samples from hip, orthopedic oncology, low back pain, and continue in the sports world with rotator cuff injuries and ACLs. We found that FAPs are capable of several different phenotypes, which may be able to be differentiated back from these degenerative pathways into a pro-myogenic or pro-regenerative phenotype. And importantly, spine pathologies likely have very similar muscle dysfunction that we see in rotator cuff, and this may be related to FAP differentiation that we'll be able to leverage with therapeutic local strategies. And if you think about the spine surgeries and the spine interventions, we already have access to the muscle because it's either directly exposed or exposed at the time of fluoroscopy. So we should be able to visualize and treat muscle once we understand the right pathways. I will conclude there, and I'm happy to take any questions. Thanks.
Thank you so much, Brian. So we have a few questions already from UC San Diego, Bahar Shahidi. Do you think that the preponderance of findings related to fatty infiltration changes compared to fibrotic changes is an artifact of the fact that scientists are typically looking at fat much more commonly than fibrosis in the spine?
Yeah, I think that's something that Roland touched on a little bit, but we have good capability to image fat, and we don't have a great capability of imaging fibrotic tissue. And there's probably a fair amount of overlap in terms of when we have fat, we also have fibrosis, but we can't pick it up as well on MRI. One of the things that we've looked at is how much of a relationship is there between the fat and fibrosis on imaging, and to be honest, we haven't been able to get too far with that just because it's so much harder to quantify fibrosis. From a clinical standpoint, we think that tissue fibrosis is important when we do a rotator cuff tear because it decreases the compliance when we do a rotator cuff repair. I simply, no matter how hard I pull, if you have a fibrotic muscle, once I attach it, it's going to spring back to where it was before if there's a lot of fibrosis.
Actually, I have a brief question. UCP1, what does it stand for?
Uncoupling protein 1.
Okay, thanks. And then Sibel asks, since it has been shown exposure to cold increases the number of beige fat cells, do you think cold compress have a potential to slow down fatty infiltration and or facilitate regeneration?
No, I think in theory, being able to chill to that level is not practical. So you're looking at trying to get something 4 centimeters deep to skin on a consistent level, enough to affect a change. It's kind of like saying, well, you can hold something temporarily in a fracture, but you can't do it 24 hours a day. I think in theory, if you said, cold therapy into a paraspinal muscle 4 centimeters deep, if you could affect that change for 2 hours a day, would that be enough? Honestly, probably not, because the signal's going for the other 22 hours. That being said, understanding that cold therapy or other things that can mimic that, we should be able to do that pharmacologically or local treatment. So I think the premise is there that altering these cells is what we want to do. And as much as I would love to say putting ice packs or UCSF proprietary ice packs on the patients would work, I just don't think that we're able to affect that level of depth of tissue without essentially frostbite.
Thank you. So I don't see any.
But it's worth, we did try to get through the IRB a proposal where we would do PET MRI and chill the patients in a refrigerator. And surprisingly, no one seemed to balk at chilling patients. They just didn't like some of the molecular mechanisms. But nobody seemed to mind doing a PET MRI after refrigerating patients.
Thank you. So I'm still a little unclear about, so beige fat cells are repair, is a repair function for if you have an injured muscle, and then beige fat cells is a component of reparation. That's what you're saying. It's not a muscle then, but it holds the muscle together, or how do I figure that?
Well, I think just like any other organ, muscle is a homogeneous set of different types of cells and FAPs that have a beige phenotype are a subset that are probably more prevalent when the muscle is undergoing regeneration. The reality is we don't know what the signal is as of yet that naturally allows FAPs to enter this beige fat phenotype, but we know that they are present even without induction. So if I randomly sample a rotator cuff muscle in a patient that has a rotator cuff tear, a significant percentage of the FAPs, about 30%, are going to be expressing a beige fat phenotype, suggesting that the muscle is trying to regenerate for a period of time at least. As the patient gets older and the patient has a larger, more degenerative condition, those FAPs tend to differentiate more into a white fat phenotype and seem to lack the plastic differentiation capabilities we see in younger patients and small tears. And one of our proposals is looking at whether or not the rotator cuff tear is essentially an accelerant of the aging phenomenon that we see in all stem cells, with alterations to telomerase activity, alterations to their histone capabilities, and whether or not it's essentially a double hit phenomenon to the stem cells that will eventually preclude their ability to improve muscle quality over time.
So I'm sorry that I have one more question. They did a study on bicyclists where they did have them work the muscles to exhaustion, the quadriceps muscle. And then they did biopsies afterwards and on both legs and massaged one of them. This was a study on the benefits of massage. But what they found is that we always thought that an injured, overstrained, overloaded muscle would have higher levels of lactate in the muscle. They kind of debunked that and found that these are muscle fiber lesions. So it's little injuries that have to heal. Is that somewhat parallel to your rotator cuff tears? So it's microscopic muscle fiber tears, but they have to repair too.
Yeah, no, that's a good question. I think when we've looked at more direct injury mechanisms, so essentially taking a punch biopsy out, we see that there's a marked increase in these para-injury areas of all stem cells. So we see over the intervening 72 to 96 hours, there's a proliferation of all stem cells in that area to effectively stimulate a reparative process. We've never done a study that is a subclinical injury, and I think that some other people are looking at with muscle strain patterns. So the NFL is very interested in this just because the number of people lost to hamstring injuries is about 20% of the league over 1 year will have a muscle strain that causes them to miss time. So the question is could you look at ways to stimulate these micro injuries to heal faster? It's a great idea. We just lack the current models to really study that at a cellular level.
Thank you. Okay, any more questions? Or maybe Jeff, you want to have some concluding words?
Thank you, Wolf. Yeah, thank you to Wolf and Roland for organizing this symposium. Thank you to all of the speakers. I think we try to organize the presentations to cover current clinical practice through novel technologies and ultimately to some potential regenerative approaches. So I'm hoping you all learn from this. Obviously, our goal here is to try to bring some of this science into the Backpack Consortium to help with developing better therapies and interventions for these back pain patients. So hopefully this stimulated some thought that would help find a path forward through our consortium. Thank you for your time and participation, and we look forward to interacting with you on a subsequent symposia that we'll be organizing in the near future.